Hello everyone, this is Chadi Alraies from CVI 2022 in Denver, Colorado. I'm really privileged to be with Dr. Salmar Arain, who is the Program Director of Interventional Cardiology Fellowship and Associate Professor at UT Houston. Salman, always nice to see you.
Chadi, a pleasure, always.
So CVI has been going on for 5 years now, and it has a different flavor. Why you are coming to CVI?
Yeah, well, I think you know this, but this is one of my favorite conferences. I think the number of reasons why I like CVI, I think the biggest reason is it's a great way for younger, aspiring interventional cardiologists to get to know the community. I think we have great meetings, the TCT, SCI, CRT, they're all doing a fantastic job. But this is one meeting where I think the young folks can get together, they can mingle with each other, see what other people are doing, be inspired. And I also feel that it has a very European flavor, like there are smaller sessions and the sessions are all case-based. So I think as someone who trains folks to be interventional, I think this is a great meeting for them. So I just love seeing the up-and-coming generation of interventional cardiologists.
Yeah, speaking about junior and also fellows, they have the opportunity to present cases and challenging cases and present at the podium.
Yes, so I think that's a great point. And actually, it's funny that this year I've noticed many fellows who are not interventional fellows. So we have young attendings, we have interventional fellows, but this year I've seen presentations done by residents. In fact, one presentation this morning was done by a third-year medical student, which is fantastic.
Wow.
Now, which other meeting lets you do that? So again, it's just fantastic. These are great, smart people. When I was a medical student, I was nowhere close to being this sophisticated. And it's wonderful to see how these people are being trained.
Absolutely. So speaking of challenging cases, one of your fellows also presenting a challenging case in a space that we are not used to go to as interventional cardiologists, which is limb ischemia in the upper extremity.
Yes.
So tell us, where this passion came from and what make you start to focus in that space?
No, I think it's really good. I think hopefully we'll be seeing more of this in the coming years. I think I was in the PAD challenging cases session. There was some upper limb ischemia, but one of the things that we've been working on is hand ischemia, especially in younger women with scleroderma. I think that's how it started. Actually, it was a resident who presented. He was involved because he's my clinic resident and he's been taking care of many of these patients. This particular case was a patient with diabetes and advanced multi-level disease. And so we treated that. And what's really fascinating is, we think about, with the inflow, which is the brachial and perhaps the ulnar, the radial, that's what the literature suggests, but there really isn't a whole lot about technique below the wrist. So I think below the wrist is really cutting edge for a lot of this upper hand ischemia, going all the way down to the distal digit. So that's what we've been doing, and that's something that I have a passion for these days.
So tell us about access, where do you get there, and what kind of equipment do you need?
So again, I think this is evolving. It's relatively new. I think one of the advantages we have now is we have very hydrophilic sheets. We have long sheets. We have the R2P system. You can go from radial to peripheral, but you can flip that. You can go from the femoral to the radial. The P to R, if you will. They often ask me, do I do brachial? And the answer is no, because I think for radiation concerns, we're working very close to the hand. And remember, these are patients who already have ulcers on their fingertips. Usually the ulnar and or the radial are occluded, and I would hate to have something happen to the brachial because that's inflow. So to avoid those complications, we often use the femoral arteries. But what's fascinating is that we can use coronary CTO techniques in actually reconstructing the superficial and deep palmar arches. And that to me is just exciting to do and to see.
Right, and in terms of equipment, you use coronary equipment because of the space, or the artery is small, or you use peripheral equipment?
I think it's a hybrid. So in my experience, again, I find myself using peripheral equipment to get down to, say, the level of the brachial artery. We use the pharmacology is all from radial access, so we use a lot of mypride and sort of calcium channel blockers to vasodilate. And then once we're actually at the wrist or in the hand, I typically find myself using, torqueable microcatheters like the Turnpike, for example. Some of the other wires, they're all coronary CTO wires. So I think it's a combination of the best of peripheral and coronary equipment.
I'm going to take a step back a little bit and see how these patients are presenting. I know in the lower limb you do ABI to screen for it.
Yes.
How about the upper extremity? It's just when they start to have tissue loss, so that's when they get referred to you? Or
correct. So these patients, by far, I think we've done close to about 30 cases in the last 2 years. By far, they're being referred to us by our rheumatology clinician colleagues. Like I said, the majority of my work is in vasculopathies, and there's women, often young women in their 30s and 40s, with non-healing finger ulcers. But obviously, once wound care sees that you do hands, then they'll say, hey, that we've got another patient. Do you mind seeing him? So the men that we've done have mostly been diabetics. This particular case was a patient of mine who came in with a cardiomyopathy. We did multivessel PCI. Then I fixed his legs, and then during a follow-up visit for his coronaries, he happened to have the hand ulcer. So that's how we picked up on it. But I think once there's awareness, people start referring you, your wound care colleagues. The vascular surgeons, not yet, though I think, it's just a matter of getting the message out.
Absolutely. Well, management afterwards, antiplatelet, aspirin, Plavix, or clopidogrel, or?
There's a lot that's unknown. I would say at the very least, yes, DAP until the wound heals. This is something that I also do for my lower extremity wounds. I think we do use, rivaroxaban, for example, in patients who can tolerate. One of the things is for scleroderma patients, they often need to be on amlodipine or some type of calcium channel blocker for the Raynaud's, because their disease mechanism is a combination of hypertrophy of the endothelium, which is you can't do anything about, vasospasm, for which you can give calcium channel blockers. Sometimes these people are on sildenafil. And the one thing I will often prescribe for patients with severe recurrent Raynaud's is nitrobid cream, maybe 2 or 3 times a day, especially if you live in a cooler climate, because that'll keep you from having the severe Raynaud's. Because ultimately, when you look at the angiogram for these patients, what they have cutoffs in the digital palmar branches. So I think they've formed thrombus in situ. So their pharmacology is a little different, but for the diabetics, the ESRD types, absolutely, the dual antiplatelet therapy and aggressive diabetes control.
Well, Salman, thanks so much for that intel and information about hand ischemia, and congrats for your fellows and trainees.
Thank you very much. Pleasure.
As an educator, you have been a very important mentor and supported a lot of graduates before. Please watch these videos and others on YouTube channel. This is Chadi Alraies from Denver, Colorado. Salman, again, thanks so much.
All right. Thank you, Chadi. Thank you very much.
Thank you.